So now that we've gone through who not to do and how to start, when you do finally decide to take the plunge, there are some stumbling blocks, and we'll go through that. So, like Dr. Pandav just said, training. That's the first and the most important thing. Unfortunately, I don't think there are any structured training modules anywhere where you can go and really train for MIGs. But it's nice in this day and age to read and watch videos, and if possible, assist. That's the best thing that can come, because you can see even assisting a MIGS requires a lot of torticollis because the microscope is tilted. So the poor assistants are usually tilted on one side. We don't realize that when we are doing surgery, because the eyepiece of the microscope cannot be tilted to the assistant. And most important is invest in a hands-on dry lab or a wet lab. Nothing works more than getting a feel of the procedure. And we did conduct a very successful MIGS workshop a couple of years ago, and we were surprised at we expected it to be a workshop for comprehensive ophthalmologists in and around Chandigarh, but people from across the country flew in and came and did that. So we realized that we maybe do this more often now. But investing in a workshop where we had Dr. Leon now come in from Manchester was really, really good. And this was like really early days of MIGS when we were also not so confident of doing it ourselves. The second thing, of course, is get the right equipment. There is no point in shortchanging yourself if you've decided to do something. A direct gonio lens, a good direct gonio lens like a Swan Jacob is our favorite, but then disposable lenses could work, except that with repeated autoclaving and ETO, they tend to become very hazy. This particular Swan Jacob, which is in the autoclave box, has been there since 2017. It's used multiply by all consultants, all senior residents, some junior residents as well. And believe me, even today I can pick it up and I can do a MIGS and there's no problem with it. So that initial cost is offset very, very well, and I always say that. Understand the funda. So as Sir said, the funda is to tilt the microscope, of course, so that the idea is that if you have the angle like this, you're not going to be able to see much. You have to tilt the patient's head so that the light from the angle goes up and falls into your eye as the surgeon. So that's the idea of tilting the head of the microscope optimally. There are some surgeons who say that you can put a mark on the microscope, but remember, every patient's head, every patient's socket, every patient's eye is different. So it's not that having a mark is going to hit the spot every time. It's around 45 degrees, but okay, it's fair to have a mark, but remember that mark may need to be adjusted with the tilt of the head and what else you need to do. So this is, it's being demonstrated on a baby because goniotomy was where we started, and that's the mother of all the MIGs really. So you do need a coupling agent on the cornea, and that's how the Swan Jacob lens gently rests on the corneal surface before you go in and you get a good look at the angle. The next stumbling block is angle visualization, and some of the people who we've spoken to who talk to us say that that's easily the most difficult thing, because usually when the person has embarked on a mixed journey, they're already proficient intraocular surgeons. So the intraocular maneuverability is not as difficult as visualizing the angle. Again, dry eye model is good. Is good. Madhu eyes are good to see that. You get a feel of holding a gonio lens, and I'm just going to take you through snapshots of our residents at the end of the OR or between cases. I tend to give them a dry lab, and so the tilt is by this cotton which is there, and the dry eye or the model is on it, and they are given a chance to hold the gonio lens. And believe me, for the first time when they assist in lots and lots of cases, they say that it's crazy, we just can't figure out how to do it. So this is really a second year JR. She's trying her best, but she's going up and down, to and fro, and this is what is going to happen to you on a live patient as well. So then it's a bit of a struggle, and this is Vaishak. He's holding fort while all of us are here. So he's come in and he's watched her struggle, and then you need a little bit of that nudge, and he says, "Arey, it's not tilted enough." So he tilts it for her. So it's important to have somebody who is along with you, but otherwise it's usually trial and error. And voila, I think she'll be able to see the angle now. So this is actually just a model eye which is tilted on an iPad in the OR to start with. The next is to train to see on fast. Now you've got the microscope in, you've got the lens in, and now there's nothing that you see. So the training is to see an on fast view of the trabecular meshwork, which means it has to be absolutely perpendicular to what surgery you're doing. And if it's a little tilted, then you're not going to be able to operate on the angle as much as you should. So this, like I'm standing on her head, but I'm telling her it's not enough. She thinks that she's taken a good view of the angle, but this is not a good view of the angle. If you have a bump of the iris which is going into the angle, when you're going to engage the angle or you're going to try and put in your instrument into it, this is going to keep coming up. So the head has to be tilted a little more. So this is what I've told her, that no, this is not good enough. Go a little more, go a little further, and you see the difference between this angle and this angle. So you might be tempted to go in and operate here thinking you've seen the angle, but the angle that you see has to be like this. You have to have visualization of the scleral spur and the trabecular meshwork, which is on fast, and the only thing that she's done is tilted that model eye a little more, but actually tilted the head a little more. So, or you tilt the microscope a little more, but this is the sort of view that you need. Now comes the real thing. You need the intraoperative dexterity for surgery of the angle. So you're holding your gonio lens. That's why the visualization is so important. Without you, before you go in, there's no way that you can manipulate the eye once your instrument is in. So now that she has an on-fast view, I've told her now you go in, and this is the view from the microscope. So she's put in the Swan Jacob lens, and this, I think this angle has been operated upon by somebody else as well. So then the dexterity of going in, I've just let her start with an MVR blade to just go and niggle the angle and get a feel of what an angle surgery would. A good starting point would be to go in with a blunt Sinski hook and do this and get a feel of manipulating the angle in every cataract surgery that you do and get the feel of it. And it's nice to do it before the lens is taken out or before the surgery is done, so that inadvertently you do your first few lens touches in a patient who you've planned cataract surgery, so it won't be so catastrophic. So this is my second year JR who has actually done a wonderful goniotomy on this model eye. And when you actually say go for it, it's really something. So once in, now this is a senior resident who's actually doing a bang once I've done the goniosynucleolysis. But the bane of MIG surgery is the air. So this happens to all of us, and he's asked the sister to inject because he wanted the iris to go down a little bit, and there you are. So this happens, and you say you've done all of that, you visualize the angle, you're ready to go in, but you put in a bit of viscoelastic, and there you are, you have this big bubble of air. So these are a little bit of the stumbling blocks when you start off, but that's okay once you get the hang of it. Best of luck, and we hope everybody joins the mixed band.